Thanks for the opportunity to present to you today. My name is Dr. Kate Rhodes. I'm a clinical psychologist working within the long-term conditions service in the health psychology department in Hywel Dda. And my Bevan project, as you can see there, is titled Integrating Psychology into Carmarthenshire Community Resource Teams. As the title suggests, the project was focused on developing a psychology pathway within Carmarthenshire Community Resource Teams. So these are primarily adult social services teams. To add a bit of context, the project was developed to meet the main principles of the Social Services and Wellbeing Act, so to support people to achieve their own wellbeing, to increase preventative services to avoid escalation of critical need, and providing service users with more control over their care. It also took into account the recommendations from the Welsh Government in 2018, outlined in the document Healthier Wales, to bring health and social care together in integrated services to support and anticipate people's health needs, to prevent illness, to reduce the impact of poor health and ultimately improve the physical and mental health and well-being of everyone throughout their lives from birth to a dignified end. So the aims of the project. The statistics show that 1 in 4 Carmarthenshire residents have a chronic health condition, and we know that many people with long-term conditions also have mental health problems, which can lead to significantly poorer outcomes and reduced quality of life. Comorbid physical and mental health difficulties have been shown to increase health and social care usage. In fact, research shows that poor physical and mental health increases cost to health and social care by at least 45% per person. Therefore, bridging the physical and mental health teams is key to delivering a seamless approach to both preventative and statutory care. So with this in mind, the project aimed to develop an innovative clinical health psychology pathway within Carmarthenshire Integrated Services for people whose psychological difficulties were impeding on their self-management and increasing their social care needs. The main aims of our project were to prevent the breakdown of care packages, to reduce the needs for costly care packages as a result of emotional distress or challenging behaviour, and to assist individuals in maintaining independence. So to achieve this, we developed a psychology pathway whereby our intervention took a three-pronged approach. We placed 3 psychologists physically in the offices of the Llanelli and Carmarthenshire community resource teams, and we offered consultation to the community resource team staff. We offered training to the staff in assessment and low-level intervention for anxiety and depression. And we also offered assessment and short-term intervention for the community resource team service users, so they could be referrals from social services teams. So consultation looked like this. It was aimed to provide advice on signposting, for example. We offered formulation work with staff. We offered advice on capacity and capacity assessments. We attended professionals meetings and MDT meetings where we were asked to. We assisted staff to put in place low-level interventions themselves. And we also acted as a bit of a bridging gap between, the social services team and, say, mental health teams, so we could make onward referrals for them if they were finding it difficult to get into things like community mental health teams. The training, so for a sustainable, accessible psychological support, the service developed a tiered care system to upskill other professionals in the assessment of common mental health difficulties and to deliver low-intensity interventions for mild presentations. So we delivered workshops to 35 adult Carmarthenshire social workers in accordance to the NICE guidelines for adults with long-term physical health problems. So we ran assessment workshops, which you can see there, were on recognising common mental health problems in long-term conditions, and treatment workshops for low-intensity psychosocial interventions for depression and anxiety in long-term conditions. The training aimed to integrate psychological skills within social care, provide access to appropriate psychological care at the most opportune moment, and providing care at the right time, in the right place, reducing onward referral and unnecessary waiting times for psychological input. So I thought it might be helpful and perhaps a bit more interesting to bring it to life and talk through a case example perhaps of one of the referrals we got to, where psychology provided both consultation with the team and assessment with the patient. So this is an example here of Mrs. A, who's a 66-year-old lady, has been living in extra care housing for the past 14 years. This is basically independent housing within a care home with set care visits a day. She uses a wheelchair and had a diagnosis of Parkinson's disease. Funding had been approved for care 4 times a day, equating to 28 hours a week. But as of late, social services have been asked to assist the care home as Mrs. A had become very demanding, calling staff out to assist her up to 70 hours a week, which was taking time away from other residents, causing them problems, and was obviously really costly. Staff no longer wanted to work with her, and the placement was at risk of breaking down. The team wondered whether Mrs. A was mentally unstable. They reported she was eating off the floor. She'd become rude towards them, was impulsive shopping. Her room was full of things she'd bought online and from the television. She was keeping staff from being able to assist other residents that needed help. She was using a lot of resources both in the care home and via social services, and therefore a psychology referral was made. So I became involved with the case. I set up consultation work with the social services team and with her care team at the housing. I then met with Mrs. A for an assessment as well, so face to face, pre-COVID. My assessment highlighted that Mrs. A was depressed. Once a social butterfly, she was now feeling lonely, being stuck in her house with no company or ways of getting out. The carers were the only people she saw. It became clear that some of her behaviour was to do with seeking company. Some of it was down to increased care needs due to Parkinson's deterioration that had not been picked up. The shopping that she was doing, we kind of hypothesized was due to boredom. It's just something for her to do. And we found out actually that eating off the floor was simply down to poor positioning from the wheelchair that she was in. There were no identifiable urgent mental health needs that I thought she needed a referral on for, but I surmised that should the situation continue, the depression would worsen. So I worked with Mrs. A to think about what was important to her, and we discussed her options going forward. I fed back my formulation to the care staff, who were able to offer a more sympathetic response and factor in time to chat to their care visits. I was able to give her the time she needed to come to a decision to move to a care home which could meet her physical and social needs better. I referred to occupational therapy, who were able to help with her mobility issues in the wheelchair to stop the eating off the floor. I fed all of this back to the team and wrote a report with recommendations. The whole intervention took up 6 hours of my time. Mrs. A has since moved and is really happy in her new home. She's now totally inactive from the social services caseload. Her previous care was costing £1,260 per week, and this has since reduced to £565 a week. That's without factoring in possible savings of preventative outcomes. So, for example, utilising mental health teams further down the line should her mental health deteriorated, or care home breakdown resulting in intermediary care. So in terms of outcomes, to date, we provided training and assessment and low-level interventions for 35 members of the Carmarthenshire Community Resource Team. The feedback from this has been really positive. You can see here some pre and post outcome measures which show basically increasing confidence by staff members to be able to assess for low-level mental health difficulties. So these are just kind of the different areas that we did some training within, so recognising symptoms, exploring these with the client, etc. You can see the lighter ones, the post confidence levels. We also worked with them to provide low level intensity interventions for anxiety and depression pre and post anxiety and depression, and these are the pre and post confidence levels of staff after they've received that training. So as you can see, they've gone up in all of the areas. The other evaluation that we did was we had a cost analysis conducted into 14 of the clinical cases where psychology provided input via the new integrated pathway, and it was found that 43% of cases led to a saving of £1.8 thousand per week, so £86,000 per year. So for 2 of the cases, costs weren't reduced, but higher costs were avoided. So for example, in one case through the avoidance of hospital admission, and in the other through avoidance of a long-term residential package. On the whole, the cases took up 100 hours of clinical psychology time, which equated to £2,984, which resulted in an overall saving of £83,000 per year. We sent out evaluation forms of our service to the social work team, but as you can imagine, during the pandemic, they've been pretty busy, so we haven't had enough of those back yet to report on. However, we've had some really positive verbal feedback from the team, including this quote from the Connectly team manager, which I won't read out because we probably run out of time. Next steps. The project's demonstrated that clinical psychology can be a valuable addition to adult social care services. We continue to offer input into Carmarthenshire community resource teams and to evaluate this work to build up our evidence base. Core investment from the Health Board or integrated funding is required to make further savings to ensure the sustainability of this working model and for further enhancement and innovation to meet strategic objectives. And literature searches to date have found no literature related to psychological issues or work in adult social care, so we hope to write up this work for journal submission. Finally, my experiences of delivering an innovation or change, the challenges and benefits. I guess developing the pathway initially felt really overwhelming and scary. It was hard to know where to start with it. We were sitting within a team that hadn't had psychology input before, and so I expected some resistance. But we were really lucky, and the team were really receptive. The referrals we received for assessment and intervention were really complex and broad in their presentations, and this could prove really challenging in respect to the input of the time needed by psychology for each service user and managing the systems around these referrals. We found that good regular supervision helped with this. We were unable to engage one of the 3 community resource teams within Carmarthenshire, and we think that's likely down to the fact that we had no physical presence in the teams. So we had staff members sitting in the other 2 teams' actual offices. The team didn't have a staff member there. So we'd imagine that in the future we could overcome this by just being physically more present. And that is it.